Hello, and welcome to OvaryActive. I'm Dr. Rebecca Dunsmoor-Su.
And I'm Dr. Amy Vodish, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause. Hi, everyone. Welcome back to OvaryActive. I'm Dr. Amy Vodish.
And I'm Dr. Rebecca Dunsmoor-Su. It's really good to have you back. Today we're going to do something a little bit different.
We're going crazy, people.
Because we're crazy, yeah. I don't know if everybody knows who's a listener, but we do actually have an Instagram where we put little clips and funny little memes and things like that. It's at Ovary_active. But on our Instagram, we asked people to ask us questions and tell us what they wanted to hear about. So we're going to do an Ask Us Anything episode and sort of address some of the questions we saw come through as best we can. Some of them may lead to full additional episodes. So we'll see how that goes.
I am not a social media user, but I'm pulling it together. I'm becoming a little more tech savvy. So it's really fun to have this. And this is a way for you guys. I think we're going to periodically do this. Submit your questions, write them in, we'll collect them, and then periodically we'll go through and answer the questions. So it's kind of fun.
It is kind of fun because it's almost like we get to have a conversation with you.
I know.
So the first question that came in is actually a really interesting one, I think, Amy. And someone actually wrote in and asked if there are any studies linking postpartum and perimenopause because they feel like the gap between those two periods is getting smaller. Also asked a little bit about, are millennials experiencing this differently? And there were a couple of thoughts that came to my mind with this question.
Yeah, it's an interesting one.
The first thing that came to my mind was, okay, so women are having babies later in life.
Mm-hmm. Yep.
And then they get into the postpartum period, and the postpartum period is characterized by very low estrogen.
Yes, it is.
And all the signs and symptoms of very low estrogen. So that's hot flashes and night sweats and dry vagina, all the things we talk about, right?
Painful intercourse. Woo.
Yep, it all happens in postpartum. How does one tell? Is this just normal postpartum or is there a perimenopause aspect to it?
I think it's a little tricky, right? I mean, I generally say time will reveal itself. I don't know if you have a different thought on that, so I'm curious to hear it. But we sort of have that time. Kind of depends a little bit, too, on if you're breastfeeding or not. So are you lactating? Are you not lactating? And certainly if you're not lactating or once you finish breastfeeding or whatever, if your periods don't resume, that's a good time to come in and get that checked. Because we'll say that you can have what you call lactational amenorrhea, meaning you're not having periods because you're lactating. And that usually is pretty reliable for about the first 6 months after you deliver. And then kind of after that, your periods may start to resume. And the reason for that is when you're lactating and when you're breastfeeding frequently, and that's the main source of your infant's milk supply, that suppresses ovulation reliably for about 6 months. And then after that, we recommend having a backup method of contraception because you may start to have rogue ovulations at that point. But if that doesn't resume for you, that would be a good time, I would say, to think about, have I just transitioned straight into having a baby, postpartum, and now I'm in menopause? I mean, it can happen. I've seen it.
Oh, absolutely. I've seen it too, especially for having babies in your late 30s, early 40s.
Yep.
You can absolutely transition straight from one to the other.
Which is really fun. Mm-hmm. So fun to be in perimenopause and menopause with a newborn. So
yeah,
that's a good
great
time for everyone. Mm-hmm. Yeah.
Although you might not notice the sleep deficit so much because, it all sort of blends together.
It just blends. You're like, are you having sleep issues? You're like, yeah, I'm up every day from 2 to 4 a.m., but that's because I'm dealing with a newborn. Oh, God.
The other thing that this sort of brought to mind is maybe this person is asking us, if you have X, Y, and Z symptoms postpartum, is that what your menopause is going to feel like?
That's a great question, right? Because it's a low estrogen state. So is this giving you sort of a signal for what menopause is going to be like for you? That's interesting. What do you think?
I don't think we know.
I don't think we know.
In all honesty, I don't think there are any studies on that.
No, I don't think so. I haven't seen anything that's been sort of comparing. It's a really interesting question just from a will this give me some insight into what fresh hell I might go through? I think it's hard because you've got the newborn component. So I think the sleep deprivation is so much worse
Right.
in the postpartum period than it is in menopause, although being up from 2 to 4 is rough when you have to sort of function.
I don't honestly know the answer to that, and it's a really interesting question if somebody
Yeah,
wants to do some research.
I know. We'd love to be involved.
Yeah, give us a call.
Yeah.
And then the last part of that question was the millennial thing. And I think you and I have heard sort of the myth that's out there that this generation got their periods much earlier than past generations, which is not a myth. That's true, which has a lot to do with the nutritional status of, kids in our country. The myth is then you'll go through menopause earlier because it feels like people think there's like a finite number of years that one cycles. And that's not exactly how it works, right?
Right. There's a lot of factors that play into it. So it's not like the earlier you have your period, then you're going to go through menopause earlier. You can have people who have their periods at age 9 and go through menopause at age 59.
Yeah.
And you can have people who have their periods at 18 and go through menopause at 40. So it's not really predictive.
That age of menopause is dependent on the quality of the eggs in the ovary.
Yeah.
And so many things impact that quality. A lot of it is just actual aging in years. So it doesn't matter if you started releasing them, they're aging at the same rate,
Mm-hmm.
no matter when you start releasing them.
Mm-hmm.
And some of it is the insults that happen to your eggs over the course of your lifetime. What have you been exposed to? All those things play into, and we can't predict.
No. The environmental exposures, your genetics, just so many different things kind of weigh into it. It's such a bummer that we can't predict it because I think it would be really helpful for people. Like if we could have a test that's like, you're going to go through menopause in 2 years, or we think you're going to go through it at age 48. It gives people something to kind of prepare for, but we don't have that crystal ball.
Although people will sell you a test.
Yes, they will sell you a test for that. And I'm going to tell you that does not exist.
No, that test does not work. And we're not going to name names because we're not going to get ourselves in trouble. But
no,
there is no valid over-the-counter test that can tell you when you're going to go through menopause or where you even are in the menopausal transition.
Nope, not at all.
And we've explained this. Your FSH is one thing this month and something else the next. And so peeing on a stick to test your FSH isn't going to tell us anything in perimenopause.
No, it is not.
A lot of these tests that people propose, whether they be blood tests or urine tests or even saliva tests, what they're actually doing is collecting your menstrual history at the same time as you're peeing on a stick. And let me tell you, if you give me your menstrual history, I can kind of predict without a stick.
Exactly. So I wish, but we don't have it yet.
No, we do not.
I know. Such a bummer. The next question is how quickly it happens, but also the patterns to notice before.
So the way I interpreted this, Amy, was how quickly can perimenopause happen? Like, can it be off one day, on the next?
Mm-hmm.
And the answer is everybody is different. Some people have absolutely no sign of it, and then their period stops.
And who are those people?
I don't know. They don't come see us.
I know. We don't see them, but it happens. Like we hear about it.
It does happen.
They're like, I don't know. It just went away one day and I was totally fine. I'm like,
Yeah.
well, I'm so happy for you, Martha, but the rest of us are suffering,
Yeah. And for some people, there can be subtle signs that turn into less subtle signs. Then it can happen over 10 years.
Right. It can be kind of this gradual buildup, right?
And then for some people, they're doing fine and all of a sudden, bam, they're up from 2 to 4 a.m. and they're having night sweats every night and they have no idea why. And then it'll go away for a couple months.
Yeah, they're like, oh, I'm fine. They're like, I don't know. That was weird. I must have been really stressed.
The answer to the question is there is absolutely no way to predict because everybody is different.
And there really isn't any pattern to say like this is coming. You and I have talked to so many different people. And so I can see patterns based on when they start talking about their symptoms, but there's like 1,000 patterns. And so we know all the patterns because we've seen them, but it's hard to say, well, it could be this pattern or this pattern or this pattern. It's just so different for everyone.
The 1,000 different patterns we've seen don't all lead to the same place, right? 2 women can have sort of the same early symptoms and have totally different perimenopause and menopausal experiences.
Absolutely. Yep.
What we often talk about in the medical literature as the pattern that tells us they're in perimenopause is the pattern of bleeding. But we all know women have symptoms long before their bleeding gets weird. And so, oftentimes they're dismissed because they're told, oh, no, you're having regular periods. So obviously you're not in perimenopause.
I was just talking to someone today whose physician wouldn't put them on estrogen because they're having regular, predictable periods with hot flashes and night sweats and mood issues and joint pain and blah, blah, blah. They would put them on progesterone for sleep, but wouldn't put them on estrogen.
But that doesn't make any sense. I mean, progesterone's lovely for sleep.
Yeah.
But it's not going to take care of all the other
No,
symptoms.
I was like, what are we doing with the other things over here? No,
Yeah.
nothing? Okay.
Yeah. And I think we should talk about what are the bleeding patterns we look for. So, people understand like my periods will start skipping, right? Or get big intervals between them. But what a lot of women don't know is that before that happens, for many women, they actually get closer together. Often the first sign is that your 28-day cycle becomes a 24-day cycle or a 22-day cycle. And then it's back to 28 and then it's back to 24. And then you start getting to the 30, 60, 90-day skips.
It can shorten and then it can elongate and eventually just go away. Although I've had people who are like, I have periods every 3 weeks. And then all of a sudden they just stop and they don't get the prolonged.
Absolutely. I have had people who said, I had a 28-day cycle to the day, every single day, and then it stopped and it was gone. And then we also both have patients who their period stops. They go 11 months, they have another one. They go 11 months, they have another one. It's like, God damn it.
I know. Sorry, we're starting the clock all over again. Yeah, sucks. So the take-home message with this whole podcast is everything is weird and crazy and unpredictable and bananas. And so your periods can be closer together. They can be further apart. It can change. So it might be one and then change into something else. But one of the things I think is important to sort of mention is when should you go in to be seen about it?
Oh, that is a good thing.
Yeah. So my general gestalt, but I would love to hear your counseling on it as well, is I will say if you feel like you're bleeding really heavy, so the volume of what you're bleeding is changing. If you feel like you're bleeding more frequently than every 21 days, or you feel like you're bleeding in between periods. Those are the 3 things I definitely want to see you back for. And then I also say, and if anything's bothering you, if you're like, this seems kind of weird, call me.
Come tell us.
Come tell us, because I might say that's totally normal, or I might be like, yeah, you're right, we should investigate that.
Those are the same things that I look for. The one thing I do tell people is your periods probably will get heavier when they start really skipping.
Yes.
So if you go 30, 60, 90 days, they're probably going to be heavier, but that doesn't mean we don't investigate it. Because one of the things we worry about when someone goes 90 days without a period is during that 90 days, they've had estrogen the whole time.
Yeah.
But they've only had progesterone, which is that protective hormone that's sort of the lawnmower of the uterus. That's only been around for the last 14.
Right.
Or not at all if they're having anovulatory bleeding. And the worry with that is that prolonged estrogen exposure without that progesterone arm can lead to changes in the cells of the uterine lining, which we call precancer or hyperplasia, or it can even lead to cancer. And we do pick this up in perimenopause.
Yeah.
And so if that's happening, you really should be seen. I mean, it does mean we're probably going to offer you some sort of biopsy, which is not the most pleasant thing we do as gynecologists.
That's fun for everyone.
We do, however, offer pain medication for that procedure, and we can make it as painless as possible. We do our best.
Yep.
It's just worth having it evaluated because, endometrial cancer is one of those really interesting things that is so easy to cure.
Yes.
If
so
we catch
easy.
it.
If we catch it. That is not the thing that is going to be the last issue that you deal with in your life. But if we can get that treated and taken care of, and with all of the sort of inconsistent hormonal signaling to the uterus, it's sort of a time that's like ripe for that to develop because your uterus is like, what do you want from me? For God's sakes, like, am I growing or am I shedding or am I staying the same? Because y'all need to get this figured out.
Yeah,
and
exactly.
So one part of the uterus is like, well, I'm going to listen to that hormone signal. And the other part's like, no, I'm going to listen to that one. And so like you're bleeding and you're shedding and you're growing and it's too much. It's just too much. Which
it is rough.
Is why, as a complex family planning person, I do love an IUD or an progestin-containing intrauterine device.
This is a very wonderful thing. It is actually also treatment.
Yes.
For some of those precancers that we just mentioned.
It can be preventative and treatment. So, and it's great for contraception for the rogue ovulation where you're like, but I'm 48 and I can't get pregnant. You're like,
Yes,
look,
you can.
Yes, you can.
It does a lot of things.
It does many things.
And it makes the bleeding lighter.
It
Because
does.
the other aspect of this is the bleeding just sucks.
It does. It's like
It
your
can be
back being
really heavy.
and you can be like a teenager where you're like out wearing like your cute little white cropped jeans. And then you're like, oh God, I'm now like bleeding through my pants. And
Yeah.
I'm like tying my shirt around my waist.
Yeah.
Like, no, like just no. So, second puberty, terrible. Bleeding patterns are wild. And that's the reason why people may notice that their periods become a lot heavier. That was one of our other questions was somebody was like, wrote in, was like, I have really heavy periods, especially in the first like 24 hours. Why are they so heavy? And in part, it's due to all of these sort of hormonal changes,
Right.
that you're
And
seeing.
even in a regularly lengthed cycle, to get those eggs out, you're probably putting in a lot more estrogen, and the estrogen makes you grow more lining.
Yeah. So you're
It's
just,
that simple.
you're laying down more 700 thread count sheets in anticipation for this pregnancy that doesn't happen. So it's just more for your uterus to expel and shed. So,
And the other thing I tell people is, sometimes that's the reason for the heavier bleeding. Sometimes it's because over the course of your life, you've grown some fibroids.
yes.
So fibroids are balls of muscle that live in the wall of the uterus. They're benign tumors,
hmm
but especially in perimenopause when the hormones are sort of all over the place, they can really grow rapidly. And depending on where they're located, they may not be directly causing the bleeding, although some can be in the cavity and directly causing bleeding. But they are in the wall or the muscle of the uterus. And to stop bleeding during a period, the uterus has to contract. And the muscles have to contract down and shut off the blood vessels.
Yep.
And if there's a big ball of muscle that doesn't contract sitting in the middle of that wall, that is not happening effectively.
Yep. It's not helping the situation.
So there are a lot of reasons why bleeding can get heavier. It's not uncommon in perimenopause. That's one of the things we deal with a lot.
If you're having bleeding in between your periods, so oftentimes we start to think about polyps. So just like you can get polyps in your colon,
Or your nose.
or your nose. I kind of describe them sometimes to people as like skin tags of your uterine lining. Like they're annoying. They're not, generally speaking, it's very uncommon. I'm not going to say zero, but it's less common for them to have like a cancer or precancer as part of them, but they can
Although
cause, they can anywhere from 1% to 5%, depending on
Mhm.
your age. And they can cause annoying bleeding patterns, like just bleeding in between your periods. And they're very vascularized. They have lots of blood flow to them. And so those are something that we can very easily treat by removing the polyp, just like your colonoscopy. And they have polyps in your colon. You can have polyps in your uterus. We just remove them during a colonoscopy of your uterus and called a hysteroscopy. And it makes that so much better. But again, something that we see a lot in perimenopause and with people having sort of this irregular bleeding pattern. So just some things
Yes.
that we want to think about when we think about bleeding.
And hysteroscopy is a really straightforward procedure.
Oh yeah, they're my
You get the nice
faves.
colonoscopy sedation, so you get a little propofol. You go to sleep, you wake up, everything's done. It takes about 15, 20 minutes, and you don't have to prep.
There's no bowel prep, honestly. Sometimes I'm just like, if I could just have like a hysteroscopy just right now, just so I could have an excuse to be like, I'm going to get sedated. I'm going to deal with the stress of my life, but I don't have to do a bowel prep. Like, this sounds great because I tell all my patients after they have their hysteroscopy that they're only allowed to binge Netflix and eat ice cream. And I'm like, sign me up. Like, this sounds great. So anyway, so the main thing being, I don't advocate for you guys going out and having unnecessary procedures to get sedation.
Right.
That
would be bad.
probably, that would be bad. And I probably need to like do a little more, I don't know, introspection into my life to figure out why I think that sounds great. However, the main point being hysteroscopies are not scary. They're not hysterectomies. So they're not scary. They're not dangerous. They have few risks with them. And if you need to do it, it's like a very simple way for us to address it. So don't be scared if your doctor
and you get a
throws that
day
out there.
off.
I know, right? Netflix and ice cream.
Love it. We have 2 comments on here
Yeah.
asking us about low libido, and then one is -0 libido. I'm not sure you can have -0 libido, although I get it.
It feels like that just disappeared. You're like, where did that go?
Yeah. It feels like the opposite of libido sometimes.
Right. You're
Tell
just
people.
like, I'm literally just like revolted by the thought of it, right? You're just like, okay. It's not that you're not interested. You're just like, oh God, dear now.
This is a huge topic. We talked about it some in one of our podcasts, so please go back and listen to the podcast with Dr. Leah Milhauser
Yep.
because She talked a lot about what's going on here.
The gift of good sex,
The gift of good sex.
the Valentine's Day episode. So go
Yes,
back if you
please
haven't
go
listened
back
to
and
it.
listen
It's
to that. Yeah.
great. Yep, Dr. Milheiser is amazing. So I definitely put a plug in for that if you haven't listened.
I do like to explain to people, while there are multiple different reasons why it's happening, I like to define it a little with my patients. Because I think often what people mean when they say they have low libido or no libido is they have no spontaneous desire. And some of that is just social conditioning. We are told by movies and TV shows and fairy smut books that we are supposed to want sex all the time and be horny as hell. And let's just recenter on what the purpose, the biological purpose of sex is. The biological purpose of intercourse is to make a baby. So for women especially who are only fertile for about 2 days a month, there is a natural time at which you might have some spontaneous desire. And the rest of the month, you're not really expected to. Now, you may love your husband or wife or partner and want to be intimate with them, but that actual chemical like ping in the brain comes with ovulation.
Yeah.
And guess what's not happening so regularly right now? Ovulation.
We're not getting the pings, people.
Yeah, no pings.
No pings.
No pings going on. So that's part of it. I think a huge part of it that we undervalue is the fact that many of us are many, many years into a relationship at this point. Dr. Milheiser talked about this. When you get into a new relationship, it does not matter if you're menopausal, perimenopausal, premenopausal, new relationship, you get that new relationship lust. It's new relationship smell. You know, it's the bonding time. You're very physical, you're very affectionate because you're creating that bond. 20 years down the line, the bond is there.
Yeah.
There's just no drive to be touching. And when we don't feel like having sex, what's the first thing we stop doing? We stop touching. We don't reach out and hold their hand. We don't give them a kiss. We don't give them a hug. We don't snuggle up on the couch because in our minds, we're thinking, oh God, if I touch him, he's going to think I want to have sex. And then I have to say no. And that feels awful. So I'm just going to withdraw. And then we're not feeling intimate with our partner because we're not touching them and kissing them and doing all the intimate things. And then that makes us withdraw more. And when you don't have spontaneous desire, what you're left with is what we call responsive desire. And responsive desire is the desire that occurs when you're feeling intimate and close and you've started the arousal pathway. So you can still have responsive desire, but you have to work for it.
It has to be something that you are consciously making a decision. Like, this is important to my relationship. It's important to me.
It feels good.
It feels good. I have conversations with patients who are like, look, I would be happy to just not have sex again with my partner, but I love my partner.
Right.
And that's important to my partner. And so therefore, it's going to be important to me. And it can go both ways. I mean, I definitely have patients who, like, if they're in a male to female relationship where their male partners are like, I'm just, and everyone thinks it's usually the other way around. And maybe it is, but it can go both ways. Regardless whether it's a same-sex relationship or whatever, So you have to kind of decide, is this something that's important to you and to your relationship that you want it to be different? In which case, the episode with Dr. Milheiser kind of really lays out a lot of the things that you can do to improve that for you. Yeah.
Right, exactly. You have to make a conscious choice.
Yeah. And it is hard for some folks where they really do feel like, as I do have some patients where they're like, I actually had a very strong libido for a very long time. And they do feel like it kind of came out of nowhere, where they're like, I love my partner. I don't feel any differently. I really want this back for me. So I don't want to make it sound like it's only situational or something has changed or whatever. Like, there can be something that feels much more abrupt for some people, but usually it's you're putting all of these pieces together.
Right.
And it's related to a variety of different things, not just a hormonal component.
Because it's not just a hormonal component, hormones are not the easy fix, unfortunately. Now, I do tell people, if you're having pain with intercourse, that is a hard stop in your brain.
Oh, yeah.
To not want to have sex. And I can fix that with hormones.
Yes, exactly.
So that will help.
Yep. We can make that better.
And using systemic hormones may solve some of the other sort of breaks on libido, like sleep issues and just not feeling well.
Right.
So that can help.
Right.
But it's
Absolutely.
not going to make you suddenly a horny bunny.
Right. No, it's not.
And I want to put this plug in, even testosterone is not going to do that if used correctly. I mean, if I give you enough testosterone, you're going to be a horny
Oh, yeah.
14-year-old boy.
Yeah.
You're also going to get a mustache.
And you may turn into the Incredible Hulk and road
Yeah.
rage. So Hulk smash, not great.
Testosterone used at normal female levels as a supplement can be mildly helpful for some women, but for some women, it doesn't do anything.
Yeah. It works about 40 to 50% of the time because that's not what the issue is.
It
right?
is not a miracle.
So we have to think about that. Despite what is being claimed
Oh,
on
yeah.
social media that that testosterone should almost be like an automatic addition to
Man, they probably put it in the water.
right in the menopausal in sort of your hormone regimen that you should absolutely everyone should have testosterone because it's going to treat your energy, it's going to treat your fatigue, you're going to feel better, you're going to feel more like yourself, and you're going to want to have sex like a horny 14-year-old boy. Like, no,
Not if used responsibly, no.
No, exactly. That's not what it's for. That is when you're using it as an anabolic steroid.
Yeah.
So,
And
so
you should
there's
also start weightlifting if you're going to do that because you can build some muscle.
serious muscle. You might start winning some CrossFit competitions,
There you go.
Okay, so we have 2 questions left on our Ask Us Anything this time. And again, we promise to do this again because I think it's kind of fun.
It
So
is.
one of the questions is, I'm going to stick with the hormone one, and then we're going to go with the one that's a little bit more of left field.
Well,
Also,
the
a
one on the
hormone.
bottom is perfect for me today, so we'll go into that.
I know, right? Okay, so second to last question is, what's your advice on synthetic hormones or bioidentical hormones? Love this question.
So it turns out bioidentical hormones are synthetically made.
What? Stop
They're
the
the
presses.
same.
Oh my God, you mean they're the same thing?
They're the same thing. Turns out no estrogen flower exists.
What? God damn it. You mean I'm not getting it through yams? Shit.
No.
Okay.
So what people are generally referring to as bioidentical hormones in the U.S. are estradiol and micronized progesterone. And these 2 molecules are made synthetically in labs.
Mhm.
They are as similar as we can make them to the natural hormones made by the body. So they have the same chemical structure as the hormones that the ovary was making.
Right. Because our ovary makes mostly estradiol and progesterone.
I think what people sometimes are thinking about when they say synthetic hormones are some of the progestins. So these are like the progesterone molecule, but slightly chemically different. And they have different names like levonorgestrel, norethindrone, medroxyprogesterone acetate. And these were all generated for different purposes. Some for contraceptive purposes, to be more strongly binding in one way. Some were generated for hormone replacement purposes to really protect the uterine lining. Sometimes they're better at getting in through the skin because progesterone does not absorb through the skin.
Nope.
So lots of different reasons why we have these progestins, all of which are safe to use. They're fine if that's the right hormone that's going to work for you.
Yeah.
We have a pantheon of options for a reason because everybody's different. And some people, we talk about natural progesterone or micronized progesterone as being fabulous and wonderful. For some people, it's awful.
Oh, it can be horrible.
It can be horrible, and
Yeah.
that's not the right medication for them.
Right. So we need to do something different.
There's a myth out there that the bioidentical ones are safer. They're not.
Love that. Love
They're
that.
not safer. All hormones have risks. They all have similar risks. It's about the doses we use and the method we use to get it in your body. So, for example, with estrogen, conjugated equine estrogens have a slightly higher risk of blood clotting than estradiol, mostly because we use estradiol through the skin and skip the liver. It's not the fundamental estrogen.
Yeah.
It's the delivery.
The big take-home message is, like you said, every hormone you're getting, whether it's from a compounding pharmacy or from your CVS, the building blocks start in a lab.
Yeah, same lab, in fact.
We can't grow them. We can't make them different. We can't do anything different. So they're all synthetic. They all have risks.
I would qualify that only by saying the compounded ones are less safe
Yes.
because we don't know what dose you're getting. There is no guarantee you're getting the dose on the bottle.
Yeah, they're not regulated. It really needs to come down to what your symptoms are and what's the right combination and formulation for you. And that can be very different. And I think a lot of times people will be like, I don't want to use like the medications that were used in the WHI, the Women's Health Initiative study, because those are the ones that showed the increased risk of breast cancer and other issues. They all have that risk.
Yeah.
So these other ones aren't safer. They're not less risky. They're, so that's the main take home
And
message.
we have studies that tell us that. There's a great study out of France called the E3N study where they download basically their entire health system every 5 years. And they look at all the progestins and the breast cancer rates. And all of them, over the course of use, slightly increase the breast cancer rate. All of them. That's the risk you're taking with using a progesterone-based hormone replacement. I also have patients who tell me they don't want to use the ones used in the WHI. And I say, why would you ever not want to use those? They're the ones we have the most data on.
Yes, they are. Those are definitely the ones that have been studied the most.
Yeah. I personally don't prescribe conjugated equine estrogens regularly because I think the way that they're generated is cruel.
Agreed.
Because the horses aren't treated particularly well.
Yeah.
But it doesn't mean that if I have somebody who's done well on them for 20 years, I'm not going to continue that. Of course I am.
They're not my go-to at all. Again, mostly because of I grew up on a farm with horses, so that's difficult for me. However, if that's what's worked for you, or we've tried other things and this is where we're at, like, okay, then that's where we go because it's an option. It's been well studied and they are safe.
I always qualify for my patients. The best data for cardiovascular protection is with oral conjugated equine estrogen.
Yeah.
We don't know that estradiol, especially not transdermal estradiol, does nearly as much for our cardiovascular system long term.
We just don't have the data because we've been using conjugated equine estrogen for longer. So that's why we have more data on it. And so we all assume that there's some benefit. Is it as good as that? We don't know.
We don't totally know. Oftentimes people are also promoting hormones as being plant-based.
Oh, Christ.
I guess technically that is correct because they're made in a lab from ingredients that did not start out as animal.
Sure. Okay.
But they're all synthetic.
They're all synthetic. Everything's made in a lab. Yeah. That's the take-home message.
Pretty much.
Okay. So,
in case you can't tell, everybody, we feel a little bit strongly about this.
Yep. I'm a little feisty over here. So we're on to our last question. I'm actually super excited about this. And I think we should do, and probably will do, an episode just on this. I think we need to, given how popular these are. But the question is, what are your opinions regarding using GLP-1 medications for weight loss during perimenopause? Just as a reminder, so GLP-1 medications, those are the medications that you're seeing probably all over your Instagram, your Facebook, your every feed, every television commercial. So this is your Ozempic, your Wegovy, your Mounjaro, your Zepbound, Saxendra. There's oral versions of this as well.
Rybelsus.
Yes. And so these are essentially those medications that people have been using for weight loss.
Great time for that question. So I am actually currently at the Obesity Medicine Association meeting in Baltimore, Maryland, learning a lot
It's
about
a very
this.
cerebral meeting I want everyone to listen to. So Rebecca will be the one to be attending that meeting. Thank you. Taking one for the team.
I am learning a ton about things I haven't thought about in a while, like liver and kidneys and stuff that as a gynecologist I can mostly ignore most of the time.
I only want to talk about how these work in the vagina. If you're going to make me think about this in other organs, I'm out. I'm out, people. Peace out.
They did mention GU systems and had one slide on it.
Okay.
Anyway.
Hey, there you go.
So let's start by talking a little bit about the medications themselves. So these are medications that were actually developed for the treatment of diabetes. So the GLP-1 is a hormone in the body, and it does multiple things throughout our body. It's actually active in pretty much every system of our body.
Kind of like estrogen. What these medications do is a combination of things. They actually work in the pancreas and the liver to help, reduce glucose levels in the blood and increase insulin secretion and things that actually help diabetics. So that's why we started with them. And GLP-1 itself, GLP-1 is actually a hormone. It's a hormone we make. We make it in our bodies. We actually make it in our stomachs. There's some in our brains. We make it in response to food. It has a lot of responsibility for us feeling satisfied. It has a lot of responsibility for how our stomach and our colon and our bowels move. The native GLP-1 that we make in our bodies has a half-life of 1 to 2 minutes. Oh,
So it doesn't last very long. But these medications, which are GLP-1 agonists, are slight variations on that molecule that last a lot longer. Some of them last a day, some of them last a week. And when they started giving these medications to diabetics, it worked great for their diabetes. And they started losing 15 to 30% of their body weight. And so somebody said, hey, these could be great weight loss drugs. And they are. They're wonderful weight loss drugs in obese patients. And that's who the studies have been done in. And what we mean by obese is people over a BMI or body mass index of 30 or over a body mass index of 27 who have associated disorders of being obese. So whether that's cardiovascular disease, diabetes, things like that. And that's who we've studied with these medications. And they can be incredibly helpful in those situations. They are not medications for people who need to lose 10 to 15 pounds. You will lose the 10 to 15 pounds, but then you will stop the medication and you'll gain back 20.
Yeah.
These are long-term medications.
Yeah.
They change the way your stomach empties. They have a lot of side effects because of that in terms of nausea and sometimes even vomiting. They change the way your brain thinks about food, so it actually reduces your hunger.
Yeah.
But that effect only lasts as long as the medication. So when we use these medications, what's critical is that you be on a program that teaches you how to live your life in a different way, how to eat differently, how to exercise differently. They can be an incredible aid in getting you to a body size where you can actually be active, because that makes a huge difference. But, when you think about them as obesity medications, we think about obesity as a chronic disease, much like diabetes, that you need to treat chronically. They're not good interventions for someone who's gained the 10 to 15 pounds of perimenopause. The other thing to think about is one of the things we're seeing with these medications is because the weight loss can be so rapid, one of the things that's lost, when you lose weight, you lose all the different tissues in your body. You're losing fat, but you're also losing muscle. And perimenopause and menopause is a time when we're already losing muscle as women. So this can actually be quite dangerous. And you may end up on the other side with a much lower resting metabolic rate because you have so much less muscle. And muscle is the calorie-hungry food, or the calorie-hungry tissue in your body. Yeah. So there are a lot of things that need to be thought about before starting these medications. They're not, just an easy weight loss solution.
This is not the fen of the 80s, people.
No, although that wasn't so good either. And one of the Fens is still on the market. So.
One of the Fens, which isn't bad, it was the other Fen.
Yeah, but the other Fen was the bad one.
Right. Mostly, I'm meaning, they shouldn't be a fad.
Right.
They shouldn't fall into I'm just going to use this for, 20 pounds, or I've got my daughter's wedding coming up and I just want to use it for a few months, or, things like that.
I mean, and the sad thing, they will work in that time, but then you get weight regain. And when you do that, it is harder then to lose that weight. Yeah.
Which is very similar with a lot of diets, right? You lose the 20 pounds on Weight Watchers, you gain the 30 pounds back. The next time you go on Weight Watchers, it's going to take even longer. You may never reach that weight loss that you were at before.
Because what we don't think about is that when we lose weight, we also slow our metabolic rate. If we're at a calorie deficit, our body adjusts to a lower metabolic rate.
Yeah.
When we start eating again, it doesn't go back up. You have fundamentally changed how your body metabolizes calorie. It's one of the reasons that what I see a lot in perimenopause, you probably do too, are women who have been so highly restrictive of their diets for decades, right? People have been eating 1,200 calories a day for decades, trying to maintain an unattainable body image. Their metabolic rate is so slow.
I know.
There's not more you can diet.
No. It's almost like they have to do the reverse.
Yeah.
They call it the reverse macro counting or whatever, where you slowly reverse dieting, where you slowly increase your food intake.
You do. Yeah.
And then you can get to a point where I'm at a normal amount of food that I'm supposed to be taking. Now I can think about how to do body composition changes. It's never about the number on the scale. It's about your body composition and how you feel in your skin. And I want to say, I am 48 years old. I am in perimenopause. I know that 10 to 15 pound weight gain where you're what is happening? None of my pants fit. It's all around my belly. I feel like a beached whale. I don't look like a beached whale. I know.
No, you do not.
I know I can say that I don't look like a beached whale. I feel like a beached whale.
There's a difference.
there's a desperation that comes with that because all the things that you used to do before aren't working. And so I get the idea behind wanting to try them. I absolutely get the obsession with
Right.
that, or I don't want to say obsession, but I get, the interest in that. And I do think these medications have been massive game changers. And I'm so glad we have them in our arsenal because obesity is such an epidemic in the United States. But I think we have to be very careful about using this willy-nilly for folks who just want to lose 10 or 15 pounds. Like, that's not really where we're going.
Yeah, and they have risks.
They do have risks. I think it'll be interesting to see as new models of this, because this is just the kind of the beginning. I think we're going to get different models, and there may be things that come out there for people who have less weight they want to lose, or that type of thing, right? So I think this is just the beginning of this class of medications. What we currently have on the market, it's really difficult because they're very difficult to get off of. And it's like, do you really want to be on something for the next 40 years?
Right. And we don't have models for tapering off. And we
No.
don't have models for maybe going down to very low maintenance doses. These things are being trialed by some of these companies, but we're years away from data on this, and we don't know how to do it and how it works. I would say that the jury is just still out. And the other thing I would add is that we don't have a lot of data on women in perimenopause and menopause. There were some in these trials, but they weren't asking specific questions to perimenopause and menopause in these trials.
Right.
This was a mixed gender, mixed age. These are all mixed gender, mixed age trials. I do clinical research on the side. I have talked to some of these companies and said, you really need to do focus studies on this age group. We have different risks and needs.
Yeah. I mean, it could be, right, that there could be data that comes out saying, actually, this could be awesome for people in perimenopause, or actually, this is really detrimental and is the exact opposite of what we should be doing for folks in perimenopause. So we don't know.
So, for example, one of the things I brought up when I was talking to one of these companies about study design, I said, so we know that a lot of people lose muscle mass with the use of these medications. What does that do to their bone mass in a time when women are already rapidly losing bone mass? Have you looked? No.
Women are just small men. Why would we need to look at them differently? Come on.
So there's questions we don't have answers to. It doesn't mean we don't use them in the right candidate in this age range. If somebody meets those criteria, then this may be a life-changing medication for them.
Yeah.
And we absolutely use them in diabetics in this age range, and they are life-changing. They're considered first line now for a lot of type 2 diabetics because we have good data that it also prevents cardiovascular disease in those patients and other, it can reduce sleep apnea in those patients. So there are a lot of benefits in the right patient.
Yeah. And I think we know as well, like right now, we had kind of talked about these BMI cutoffs, and as we know, BMI is not like
It's not ideal.
It's not ideal. So I think we need to come up as a medical society with better criteria because there may be people with a BMI of 25 who actually would really benefit, right? And so maybe these cutoffs are a little too arbitrary and also
male-centered.
Yes, white male-centered. Yes, thank you.
They are. And we're actually talking about that at this meeting. They've already started to say, for Asians, South Asians, like there are different BMIs that we need to be using a cutoff for because it differs.
Right, for sure.
Ethnically and culturally. And I think also BMI is not a great calculation. There are better measurements. We should be measuring a person's body composition.
Yes,
and looking
exactly.
at their fat to muscle ratios.
Yep. I actually think that's a much better because there are folks who are small, like you wouldn't look at them and say they're obese, but their body fat percentage is extremely high.
Right.
And they may have insulin resistance and all these other things, but they're not diabetic. They don't meet BMI criteria. They're not overweight. Like they don't have these other things, but from an overall health perspective, these could be really big game changers. So I think obviously, this is like a great question because there's so much out there that we don't know.
We need a whole episode on it.
We need a whole episode on it.
Well, I would love to do a whole episode on all of the weight loss medications that are out there.
Because there's more than just GLP-1s. I mean, we talked about fen-phen. We lost one of the phens, but we still have the other fen.
We still have the other fen.
And it's actually something to think about. And there are medications that have less side effects or different side effects. They're pills. They're not injections. They're this, they're that. So I think a whole episode.
There are a whole host of medications that are really good at helping women or people in general to lose anywhere between 5 and 10% of their body weight, which is sort of what we're talking about here, right? they're medications that, when combined with the right lifestyle interventions, can actually be incredibly successful.
And you can wean off of them.
And you can wean off of them.
Right? So that's something to
More
think
easily.
about.
I mean, in
More
theory, we
easily.
can wean off of these too. We just don't really know how yet. And I think sometimes the effect of them is so dramatic that people don't have to do the work
Yeah, exactly.
to change their lifestyle.
Right. They're like, I just take this and I don't have to do anything. It's like, oh, there's no easy fix. There's no free lunch, people.
There's never a free lunch.
Never a free lunch. Well, on that note, this has been super fun. I can't wait to do another one of these. So if you have questions, send them to our Instagram.
Yes, please.
We are collecting them all. And so we'll just periodically do these episodes. And remember, it's at @ovary_active.
Yes, that's us. And remember, you're not crazy. This is really happening.